Welcome to the lecture on special service settings, military and veterans care. So mental health care is different according to whether or not the person is active duty or whether or not they're now considered a veteran. So active military are served through the health systems within their branch of service and TRICARE, their insurance program. After separation, however, they become a veteran and then they deal with the veteran health system. Mental health treatment has different issues and challenges for persons in each category. Problems with the transition from one system to the other has attracted much needed congressional and public attention. This graph depicts the size of the U.S. Armed Forces. You can see, obviously, the Air Force is the largest branch of our military, and the Army being the smallest. In this graph, you can see the percentage of active duty military personnel with self-reported serious psychological distress. There is a difference between the different branches. You can see that the Marines actually report a slightly higher percentage of serious psychological distress in the last 12 months. They also have a slightly higher percentage of need for further PTSD evaluation, a slightly higher need for further anxiety evaluation, and a higher need for depression evaluation. And there are policy issues for military mental health service systems. Um, Policies for screening and referring for mental health disorders. By policy, there's less confidentiality than in civilian settings. There's concern regarding impact on future in the military. Is this going to create a stigma, affect their position? And then the stigma and prejudice associated with whatever that diagnosis might be. There's an increased need for and recruitment of personnel to provide assessment and interventions in deployment locations. And there's a need for mental health services on bases for return military personnel and families, accessible services from military or civilian providers that are reimbursed through TRICARE. This graph depicts the eligible TRICARE beneficiaries as of 2017. You can see the largest proportion are less than 65 years of age, retirees and family members, just at 3.18 million, followed by retirees and family members that are at or greater than 65 years old, about 24%. From these two graphs, when we look at veteran statistics, you can see that there has been a steady increase in outpatient visits, and there's also been a steady increase in disability for veterans. This table depicts the estimated mental health need in veterans, and you can see here that any mental health need based on positive screening was about 41% of the sample. And the largest mental health need obviously was for PTSD, followed by depression. However, as you can see the note at the bottom, the percentages don't sum to 100% because veterans can have comorbidity. They may screen positive for more than one condition. So let's talk a little bit about policy issues for veteran mental health services. First, there's confusion about who's eligible for VA care. Two-step enrollment processes are still in play. There's concerns about impact of mental health care on continuing VA service eligibility. There's eligibility status related to terms of discharge other than honorable discharge disqualifies. There's also misinformation regarding impact on employment, security clearances, and gun ownership, and some concerns are valid. There are some long waits to get enrolled for VA care, appointments with providers, transition paperwork, and eligibility sorted out. Reports in the mid-2014 timeframe showed, highlighted the long waits for persons with PTSD. Assessments for PTSD and suicide occur at discharge from active duty, but reassessment over time is still needed. Continuing our discussion on policy issues for veterans in mental health services, we've got women whose trauma resulted from military sexual assault or harassment have found it difficult to qualify for care. Military sexual trauma for both women and men were initially not acknowledged. Distance to VA services for those in rural areas or without their own transportation. There's an inadequate supply of mental health professionals prepared to serve veterans, especially those with PTSD, in VA facilities and community services. Other than honorable discharge as possible consequence of mental health problem, and there's an elevated suicide rate and service eligibility. Let's talk about what actions have been taken to improve access to VA services. There's been an expansion of vet centers and their use for mental health care due to separated record keeping systems, greater use of teletherapy for persons at a distance, expansion of combat related VA healthcare eligibility to 5 years post discharge, simplified eligibility based upon 9 disease classifications. The Caregiver and Veterans Omnibus Health Services Act of 2010, which offers stipends, covers expenses, and other benefits for veterans with severe injuries and their caregivers. Veterans Access, Choice, and Accountability Act of 2014 aims to increase access to healthcare by use of providers outside the VA system, and emergency stabilization and treatment for up to 90 days for persons at suicide risk who are other than honorably discharged. Here are some initiatives to address the problems for VA services. The VA Center for PTSD with resources for veterans, families, and professionals. Explicit policy for military sexual trauma that expands evidence that can be used to claim services and does not require service connected to be eligible for services. VA website offers information for veterans and providers. Attention and screening for suicide, the VA hotline, training of community mental health practitioners, changes to facilitate community care where VA care is not easily available.